Thank you, Professor Linda Gale, for the introduction. Good afternoon to you all. So first speaker in the afternoon after meals. So that's the outline of my presentation. I'm going to talk about the definition of combination prevention, some of the strategies, how to develop a good combination prevention strategy, a little bit about adolescents and HIV, some of the drivers of the epidemic among the adolescents, barriers to effective combination prevention, and some recommendations. But I encourage you all to add some more based on your areas of expertise. So I have no conflicts to declare. So I would like to start with a definition of combination prevention. It's a rights-based, evidence-informed, and community-owned programs that use combination of biomedical, behavior, and structure interventions designed to meet the current HIV prevention needs with specific people and community. This is a UNAIDS definition, and for our case, we are now talking about the adolescents. And the goal is to reduce the number of HIV infections, new infections, through activities with greater sustained impact. So that slide basically shows you how all these three come into play: the biomedical, the structure, and the behavior. And you can see that we have a lot going on the biomedical side. And I think from one of the opening sessions, we saw that the science is there, the biomedical are there, but the challenge is the structure. I think I'm hearing a lot about the structure interventions, where we're having quite a number of challenges. So I think we also need to focus most of our efforts on the structural interventions if we are to have a very good combination prevention strategy. And this slide basically tells you that it's not a matter of combining the biomedical, the behavioral, the structure. The way it is done has to be a well thought out process. It involves a multidisciplinary approach. And I just like this that says that all effective interventions are not equal. So it means that we really have to really think about this and designing combination prevention strategies that can work well for the adolescents. So what does a good combination prevention strategy comprise of? It should be tailored to the national and local needs based on epidemiological information. It should have the resources concentrated on combining activities where they're most needed, and the affected communities should be fully involved in these programs or in designing these strategies. I think I'm hearing a lot about community involvement in this conference, and I think if you're to develop a package for adolescents, it's very important that adolescents are part of the process. Otherwise, there will be issues of sustainability of that program or that strategy. And the strategies should be comprehensive. We should also consider that when we are planning for the best combination prevention strategies, they need to be inclusive. I think I've mentioned this already, transparent and evidence-informed. We need to also identify the relative modes of HIV transmission. I like the statement, know your epidemic, know your response. So if we are dealing with adolescents, what are the drivers of the epidemic among the adolescents? What is putting the adolescents at risk of HIV? We need to also identify the geographic patterns where the new infections are happening and focus our services where they're most needed, and also to estimate the size of the key populations, and this is more important in terms of resource allocation. We need to also identify the structural factors that increase the risk and vulnerability or reduce the reach and impact of prevention packages or strategies. And we need to analyze the available research concerning the social, cultural, economic, and political forces and conditions that contribute to HIV transmission, and also analyze the existing gaps and close them. So this slide basically shows that all these have to come into play. We need to look at critical enablers, and all these have to be in a synergistic fashion. We don't only have to look at the biomedical, the structure, but we also have to look at other issues like poverty reduction, gender-based violence. How do we reduce that? We need to look into the health systems, community systems, and employer practices. So now I'll turn to the adolescents and HIV. This is just a little statistics showing the burden of HIV among adolescents. This I got from the UNAIDS report. And in 2020 alone, we had 1.75 million adolescents between the ages of 10 and 19 living with HIV worldwide. And in And we also have 410,000 young people between the ages of 10 to 24 newly infected. I think yesterday I heard that a young girl gets infected every 2 minutes. I think that is very sad. It's something that we really need to work on, especially in adolescents. So 10 to 19 is really a critical age that we need to work on to ensure that we reduce the HIV infections in the young people. And the third point shows that HIV testing among young people is also still very low. One thing we also need to appreciate that we are in, I think it's been about 40 years since this epidemic has been ongoing. And we have a number of children who are infected with HIV perinatally, now growing into adolescence or young adulthood. And we need to see how do we support these young adolescents to have healthy sexual lives. I'm very happy that at this conference we are talking about U equals U. And I think we really need to message U equals U among adolescents who are living with HIV and how can we support them to have healthy sexual lives. In 2015, UNICEF and UNAIDS, in partnership with other international health and development partners, launched an all-in to end adolescent AIDS. And this is by 2030. And to achieve this, it is critical to accelerate efforts to address the epidemic among adolescents. You may say that, are there any combination preventions for adolescents? Yes, work is being done around adolescents to reduce the HIV infections. And there's been a decrease by 1/3 since 2010. However, the progress is slower than what we are seeing in PMTCT. And what are some of the major drivers of the epidemic among adolescents? We have low HIV testing among adolescents. I've already alluded to this. It remains as low as 20%. And then we also have poor access to treatment. About 50% of adolescent boys and girls are able to access treatment, antiretroviral treatment, those who are living with HIV. We have lack of knowledge on sexual reproductive health, including comprehensive HIV prevention knowledge. The knowledge rates remain at below 50%, especially for the non-school going adolescents. One thing we need to appreciate is that most of our young people were not there in the 80s and the I think it was the 80s, when the epidemic was really bad. So they can't really appreciate what some of us saw. So we need to actually continue to educate our young people about HIV so that they can know what it's about and how they can protect themselves. And then we also note that adolescents have poor access to health services, and some of them are not even adolescent-friendly. And we also have an increased concern of mental health among adolescents. And the reason for this could be as a result of intimate partner violence, stigma and discrimination, early childhood marriages, gender-based violence. And then other drivers are transactional sex is on the rise among adolescents. We have age-disparate relationships, and there's complacency about HIV among adolescents. Other issues, we have very good products on the market. We have oral PrEP on the market. It's been there for a while. But we still see some challenges among adolescents with regards to adherence, especially also use of lifelong ARVs, for various reasons like side effects, disclosure, stigma, and gender-based violence. And then we also have issues with the healthcare workers. Some healthcare workers are still not accepting enough or comfortable with providing sexual reproductive services to adolescents. And then we also have issues of gender discrimination. So what are some of the barriers to effective combination prevention for adolescents? I'm sure you've had some of these already. Some are political, structural, or individual. We still have issues of restrictive laws and policies, issues of criminalization, age of consent. I think this is an area we really need to work on if our adolescents are to be able to access reproductive health services comfortably. We see that some countries have lowered this age of consent to as low as 15, but some countries still have it higher. And so we find that parents and guardians are really a barrier to most of the adolescents accessing reproductive health services. And then There's lack of an enabling environment that allows for meaningful engagement of adolescents in HIV-related processes. We usually design most of these activities or strategies, but we forget to involve the end users who are the adolescents. So it's important that they're involved in the process. And then there are issues of stigma and discrimination, access to health services, lack of resources. And as I mentioned earlier, when we are looking at the biomedical structure and behavior and designing these combination packages, there are challenges in making packages that are feasible, effective, and affordable, that are community or population specific and acceptable. And some of the reasons could be limited integration of these approaches. Some of the approaches are focusing on the individual risk, reducing the risk, as opposed to putting more efforts on addressing societal factors that increase vulnerability. And some of these packages lack synergism. And then we also have weak approaches in implementing, monitoring, and evaluating our HIV prevention programs. So what are some of the recommendations? These are a few from my side, but you can add. There's an urgent need for greater demand and greater support from communities and policymakers for rights-based evidence-informed combination prevention. And then we need to have in place effective implementation of combination prevention. It requires sufficient personnel to define and tailor programs, to synthesize available evidence, to manage multi-component programs for specific results, and to conduct and apply needed research, and to implement robust monitoring and evaluation. And then we also need to make a continuous needs assessment while designing these programs. Right now we have Kabele approved for use. We have the dapivirine vaginal ring. How do we incorporate this into the current prevention strategies? And then we need to look into integration of services, including mental health, screening for IPV, sexual violence, to mention but a few. And we need to have favorable laws and policies that eliminate criminalization, strict stigma, and discrimination. Thank you so much for listening.